Thank you for joining us for today's Nuts and Bolts of New Ideas Reimbursement. This webinar will be presented by Ms. Denise Merlino, founder and president of Merlino Healthcare Consulting. Ms. Merlino is a nuclear medicine technologist, certified professional coder, and a health policy consultant with over 45 years of experience. She has provided reimbursement guidance for many professional societies, pharmaceutical companies, imaging, and biotechnology companies. She provides consulting for the AMA CPT and ROOC, and educational and health policy strategy for several professional medical specialty societies, including the Society of Nuclear Medicine and Molecular Imaging. And with that, Denise, if you'd like to begin.
Thank you, Christina, and welcome everybody. So today we're going to review the New Ideas program. So many of you might have participated in NOPR, the National Oncologic Registry, or maybe you participated in the first clinical trial of ideas. But this is a new clinical trial referred to as New Ideas, really novel, catchy title. So we will be going over, just reminding everybody what the coding and billing guidance is, where they can find the resources, and some example claim forms. So this is really not super new news, but it is information that some of you might find very helpful. So right now I have up my presenter disclosure slide so that you can have that information, and I believe it's also available through the SNMMI website for any of the presentations that I do. So again, as I mentioned, this is a webinar that is going to go over some of the basics. So bear with me if you're an expert on coding and billing, or if you've done this before. It's more of a refresher to make sure that everybody's up to speed that might be participating in the New Ideas clinical trial. So we will cover the topics of the Medicare billing guidance, what the basics of the CPT procedure codes are, what the basics of the HCPCS level 2 radiopharmaceutical codes are, what the national payment rates are. We will go over some of the basics that are important to participating in a clinical trial and how that relates to how you're going to send the claim out the door. We'll talk about the responsibility of the patient and the copays. And then we'll talk a little bit about the Medicare Advantage plans, the Medicare administrative contractors, and how, if you do get denials, how those can be resolved. And at the end, we will take questions. So we'll start with the Medicare guidance that's out there and who's actually eligible for New Ideas. So similar to the original ideas, first, the Medicare patient must meet the ideas criteria for the study. So while this presentation is not to go over the criteria of the study and whether or not they meet the criteria, this is how do you bill it, assuming that they've met the criteria. So that's the first thing, is they must be eligible. The second thing is they need to be Medicare as a primary and not as a secondary insurance. And they must be part of the Part B program. So Part B can either be a Medicare Advantage plan, or it can be through the Medicare administrative contractors. And then there will be a little bit of a discussion on the Medigap plans, because most of the population out there, at least 60% of the population of Medicare does have some kind of supplemental, what they refer to as a Medigap plan. And so those plans do tend to pick up the copays and the deductibles, but not always. So we will talk about how to deal with that as well. So the next couple of slides, I'm really not going to read this off to you, because what they're here for is a reference. So if a payer is telling you, whether it's the Medicare administrative contractor, so your MAC, and there are several of them across the country, or whether or not it's a Medicare Advantage plan. And those Advantage plans, there can be lots of them out there. So if any of those folks are saying, we don't know what this new ideas is, what is this clinical trial, and are you sure that it's covered and paid for, that's what these transmittals speak to. It speaks to how beta amyloid is actually covered and paid for based on the national coverage determination. It has billing guidance in the Medicare claims processing manual. And then slide 7 refers to all of the transmittals that are out there. Now you'll notice some of these are older because IDEAS was out quite some time ago. And there was a slow start to IDEAS because CMS approved the clinical trial. We were ready to go with the clinical trial, but CMS hadn't actually put out some of the transmittals. But the transmittals are still there. They have not been deleted, although there might be some contractors that forgot about them, although we're trying to make sure they're at least alerted to the fact that new IDEAS is up and running. So these are just references on slides 6 and 7. On slide 8 is a reference to the fact that the Medicare Advantage plans have been communicated to about the fact that there is a clinical trial out there, and they are responsible to pay for these. And although they do a lot of different activities, so the individual you may talk to may or may not be aware of new IDEAS. It is not uncommon to run across this situation, but it can be easily rectified. And that's why we're showing you all these different references so that you can talk to the MA plans with any information that's necessary. So bottom line is that the MA plans are required to accept new IDEAS patients into their system. They cannot deny them, but they do have different requirements, and they would not have a Medigap plan. So their co-payments and their deductibles are not waived. And so the patients do have the responsibility for those co-payments when they're in that situation. Slide 10 just speaks to this is a clinical trial, and in any clinical trial, when you're submitting the claims, there's an 8-digit clinical trial number that has to go on the claims. And I'm going to show you on the next slide, and then also on some sample claims where those go. This slide also has the references to what's required to actually be put on the claim forms. So, but we're going to go through all of that. The important number here is clinical trials number 044-26539. So that is going to differentiate this from the original IDEAS. And so it will trigger to the payer that this is the new IDEAS clinical trial. And it was approved in April of 21st of 2020, so last year. All right, so now we're going to talk about the coding and the payment and the different care settings, because I know that the care settings can be an area that is confusing to some providers. So just as a frame of reference, and this slide also has all the acronyms listed. So if I throw around terminology like MAC, Medicare Administrative Contractor, that is spelled out on this slide. If I talk about an APC grouping or a DRG grouping, at the top I have listed all the abbreviations. So bottom line is that if it's a Medicare patient, I don't care whether it's a Medicare Advantage plan or if it's a traditional Medicare patient, there are going to be different designations put on the claim form. And the reason those designations are important is because it will trigger which payment system it's going to be paid under. So for instance, if you happen to do an inpatient, then that's going to be paid under the DRG. So basically it's going to be a bundled payment. You're not going to see any additional dollars for the technical component. If it's done under place of service number 22, that's considered an on-campus hospital outpatient facility. There's a designation that came around a couple of years ago referred to as an off-campus hospital outpatient payment system category, and that's designated with a 19. So your folks in the financial department and the billing department, they're going to know how your site is set up. So if you're a nuclear medicine tech, you probably don't know the answer to how the claim is going out the door, but all you need to do is talk to your folks in finance and you'll be able to find out, are they submitting a place of service of 19 or 22 or 11? That triggers, that's how you're going to know which payment system and how much money you're supposed to get for the service. And then slide that I have up right now that talks about the comparison of the physician fee schedule to the hospital outpatient. The major difference in the two systems is that one is kind of set up like a DRG system where things are packaged and bundled, and that's the hospital outpatient system. So the drugs and different services, they're packaged and bundled like a mini DRG in order to set the payment rate. Whereas in the physician fee schedule, those are based on relative value units. And in that system, the radiopharm is paid separate from the procedure. So those are the two major differences and the major questions that we get on the different payment systems. So what codes are you going to use? It's no different than the first IDEAS study. It is 78811 or 78814. Don't be confused and don't use the brain imaging code because that's for metabolic evaluation. And if you are doing the PET MRI, you're going to use 78811 along with whatever MRI code goes forward. And then if you are if you're doing a PET CT, then you're going to use the 78814 code. So I think that's those are kind of the major tips with regard to procedure coding. For radiopharm coding, you need to know what product you've given. So we've listed the 3 different brand names, the NDC numbers, the description for each of the products. And in this case, it's fairly straightforward, unlike some of the other nuclear medicine procedures, in that each of the radio tracers are described per study dose. So that makes it helpful in that your unit of the HCPCS code is always going to be 1. It's not going to be per however millicuries it is. It wouldn't be 8.1 or 8.6 or it's going to be 1 because it's per study dose and you're only going to do 1 study. What are you going to get paid? So if you're in the hospital outpatient setting, I have listed the payment rate for hospital in red for each of the 2 codes. And if you are in the physician fee schedule, these are contractor priced services. Most often we see the contractors using what's called the OPPS cap. So it's the highest amount that the physician fee schedule could be paid. And that is basically the HOPS rate. And then every now and again, you will see a contractor who pays less than what the HOPS rate cap is because they know they're going to pay for the radiopharm separately. So they try to strip out the costs of the tracer. So notice that the CPT code has a TC after it. So that's just for the technical procedure. The next slide is going to show you what is the doc going to be paid for the reading of the study. So I did list the national rate and then the 20% copay. And these are just ballparks because you have to also remember that there's going to be a wage adjustment based on the locality you're in. So this is what we call a geographic adjuster of 1.0. So basically no adjuster. It's not less than national average. It's not more than it. It's right at the average. So let's talk about co-insurance, which includes the co-payment and deductibles, because I get this question quite often. If somebody doesn't have their deductibles covered by a Medigap plan, it's possible that if somebody has a very high deductible for their MA plan, that the procedure might not even be covered. So I think those are the types of questions you have to really understand so that the patient fully is aware of whatever the costs might be. But the co-insurance or the co-payment for the procedure is generally 20%. So you can see it's going to be roughly somewhere between $254 and $289. For the reading of it, it's going to be roughly $15 to $18. And then in the physician office setting, it's typically 20% of the drug. And when they're paying for the drug, they'll either ask you for an invoice price or they'll be paying based on an AWP. Each contractor is allowed to set that price individually. And if you have a problem with it or if they're underpaying, sometimes we have to have conversations with them. We've had examples where a third party is supplying that MA plan with pricing information and they've misunderstood the Red Book or the Medispan price, the AWP, and they've translated the price wrong. So we've had to do a little digging, and the Society of Nuclear Medicine and Molecular Imaging, along with ideas, we work with you and we work with those different companies to try to get that corrected. But it does happen. So you do have to watch what you're actually getting paid for these. So what are the diagnosis codes that you're going to be using? It's going to be one of the list here. This is what CMS has actually put out that are considered covered nationally. So if you list any one of these in the primary procedure code, you won't have any problem with getting paid. Logistics. So there are some complexities to ideas that you do not have with just a regular study you're doing. That's not a clinical trial. And this is probably, if you've not ever participated in NOPR and you've not ever participated in ideas, this is the one piece that you have to change the flow in your department, because generally what happens is the patient comes in, the patient gets their exam, and then the bill goes out the door. And what has to happen with ideas studies and NOPR studies is, because you're part of a clinical trial, it's required that something else has to happen after the scan is performed, and that something else has to occur before you can bill. And you need to have documentation about it. So that's why we say hold the claims until the elements of the new ideas are met. And this applies to the technical and the reading. So whether it's the site that's performing it or the doc who's reading the study. But basically what will happen is the physician is going to complete a form 7 days after the PET is completed. And once that occurs, there's an email that comes in. And you got to kind of find out in your facility who's going to get that email and make sure that the billers have a copy of it so they can put it in their billing file. So this is probably the thing that you have to make happen in your facility so that if you are audited on this later on, you do have a paper trail that you met the elements of NOPR, and the email, is what we say, triggers that. So these next slides are actually from the IDEAS trial team. And so it's the process that you go forward with your amyloid PET report. So the form becomes available after the completion, and you basically are going to need to have the interpreting physician complete the form. And the next one shows you the individual who's going to upload the report into the system. And then the next one is going to show you you're going to receive an email. Now, this does say the scan was completed in 2015, and we know that that this is an example of the original IDEAS, but the form looks exactly the same of what you're going to receive. So this is the form that we want the billers to keep in their file. This is a reminder. This is not a new piece of information. This is anybody who operates in an independent diagnostic testing facility. So I had that, I showed that earlier on in the slide when we were talking about the different settings of care. If you have not participated in the original IDEAS and you're going to participate in new IDEAS, you must fill out the 855B form so that you can add the radio tracers as well as the CPT codes if you don't already have them in your system. And this is really important because if you submit a claim with HCPCS codes that you don't have identified by that administrative contractor, they will just reject and not pay for your claim. So we found that out, that some sites skipped this step originally that were IDTFs because we didn't spell it out and we didn't remind folks that these are services that they're required to list before they can actually bill. So you actually have to have, the MAC needs to confirm with you that you can perform those services. So don't jump the gun. There are lots of PET resources out there if you need some help. This slide 27 shows you the Medicare coverage database, which shows the coverage for amyloid studies. We also have elements of PET CT reporting. We have some question and answers on the new IDEAS website. There are also resources, and we also have sample claim forms, which are on both IDEAS and the Society of Nuclear Medicine's website. So for simplicity, let's just have you sticking to the IDEAS study website. And if you follow the arrows, and I'm not sure, I don't think you can actually see me pointing to things on here, but there's an arrow that says during this study, and then there's an arrow that shows Medicare reimbursement. So you may have to go through a couple pages in order to get to Medicare reimbursement. But then once you're in Medicare reimbursement, there's information about what's the clinical trial number, all those transmittals. If you just click on the blue text, it will take you to that actual transmittal. Or if you want to go to our reimbursement frequently asked questions, you can click on that link. So we tried to give you all of the resources that you would need to give to your biller. And then the next series of slides are examples of sample claim forms. And again, these are the types of things that you would want to give to your biller to show this is the detail in which we're going to submit the claims. Now, on a screen, if you're looking at a regular screen, this is probably very small, but you're able to download these off the website and print them up, and they are 8 by 10 pages. So you should be able to take a look. But the first form that you're looking at on slide number 30 shows you where you're going to put the revenue code, what the correct revenue code is, where you're going to put the CPT code, and the fact that you need to append a Q0 modifier. It also says there's a D4 position, and that's where you're going to put the clinical trial number. You also have to put 30 in, it's a condition code as a qualifier. So we put all the different locations. We also put the primary ICD-10 code along with the secondary ICD-10 code. So this is the example, and I do have a slide coming up that says all of these things that have to be on the claim form. And I can tell you that there certainly is a lot of things you have to remember. So this is why if you do get a denied claim, the first thing we do is we ask for an EOB. We want to see how you actually sent the claim out the door and what was the rejection notice that came back. And comparing these, we can actually tell whether at least you submitted it correctly. That's kind of the first step. And if you didn't, then we get it corrected. And then if it's an issue with the payer because you did everything right, then that's kind of the second step. So this is an institutional claim form. So this is for a hospital outpatient setting. It's referred to as a 1450 claim form. And slide number 31 is an example of billing out for the hospital reading. So you're still gonna, how you identify the reading of a study is the modifier 26, but then you're still gonna have to have the Q0 modifier as well as a KX that is going to identify that you're in a clinical trial. So there are definitely more steps that you have to go through in a clinical trial, that it is different from billing a traditional PET study. So again, these are all the important steps. But if your billers have participated in either NOPA or IDEAS, they're going to get this pretty quickly. Or if they've participated in any other studies. These are all kind of normal processes that we have to go through if it's a clinical trial. Slide number 32 is for Medicare or managed care. And again, it's just another example showing all the different CPT codes and modifiers and how you're going to report the ICD-10 codes. And this is on a 1500 claim form. And this is slide 33 is for an independent diagnostic testing facility. So these would just have different designations of the place of service and giving you all the specifics. And slide 34 is a sample physician office claim form. And this is if you're billing globally. And globally means that you're going to bill for both the professional and the technical together. So there's no modifier that's just a technical only, or a modifier that's the professional only, which that is 26, which I mentioned on my last example. Slide 35 has all of the intricacies and things that are different from a sample. So the billing specifics, that if you are an institutional claim, so that's another phrase for if you're in the hospital setting, you're going to need to use condition code 30. So if the 30 is not on there, they're not going to be able to process the claim because it's not going to really identify it correctly. You do have to have the Q0 modifier on both the CPT code and the radiopharmaceutical HCPCS level 2 code. Based on whether or not it's 1450 claim form or a 1500 claim form, the clinical trial number goes in different locations. So one is referred to as a D4 position, another one is referred to as the P4 position. So those are triggers that if you're talking to a biller and they say, you know, they're putting it in the D4, you know that that's an institutional claim, that that's a 1450. So those are the type of triggering pieces of information that might be helpful to you. And then another thing that's important is that the ICD-10 code that list of one pager that I showed you, that's the primary, that goes in the primary position, and then there are secondary positions. You have to put the Z00.6 in that secondary position. So these are all kind of the little bit more unusual things that you have to do. So here's some commonly asked questions that we get. Do I append the Q0 modifier on the amyloid PET scans? So as I mentioned, yes, you need to append it to not only the procedure code, but also put it on the radiopharm code. We have found out that most of the MACs are requiring it. And if you were to put it on there and they didn't require it, it wouldn't reject. So better safe than sorry. For those of you out there doing PET scans for oncologic indications, your billers are probably very used to those two modifiers, PI and PS. And we're going to tell you right now, they get a little confused, and you got to say the PI and the PS does not apply to amyloid studies. So that is not a modifier they are going to or need to use on the claims. And every now and again, we get a claim that comes back and a MAC that says they're looking for the PI or the PS. And it's because their systems have been programmed incorrectly. So sometimes we have to work through that, but the bottom line is you should never have to put a PI or a PS on an amyloid study. Another common question we get is the limit of one scan per year or for patient's lifetime. And it is per patient's lifetime. So we've gotten that billing question quite a bit. And I'm just going to remind you, because we're getting close to the end of my prepared slides, that if you do have some questions, go ahead and type them now into the chat box. Actually, it's into the Q&A box. And once we're done with the slides, we'll go back, see if you have any questions that I can answer. And we'll take it from there. So slide number 38 does show the different MAC jurisdictions. It may be a little old right now because it's not 2021, but I think these are still current as of today, because I did look it up on the website and I don't think any of those had changed. Slide number 39 is, what do I do if my claim denies? So this is the checklist that we're going to ask you to use. We do ask you to please verify that you've reviewed the sample claim forms and compared them and read some of the FAQs, because a lot of times you can answer your own questions before it even gets to it. But if you do need to send us in your sample claim form, please go ahead and do that and fill this form out. If you have lots of ones that are denied, that's what the back of the form is. There's two important pieces of information that we need if we're going to work with the payer. We have to have the date of service that the scan was provided, and we have to have what's called an ICN number. It is the way payers actually track these services. So if you're going to ask for our help, what we want to also tell you is please continue to go through the appeal process while you're working with us. Don't expect that we're going to fix everything. That what we want you to do is keep appealing the denials, going through the normal process, and we will work with you through that process, but we don't want you to miss any of the deadlines because that's really important. If you don't keep following the process of the denials, then you potentially could be in a situation where, because you didn't appeal, you lose your appeal right. So we don't want that to happen. So now we're going to just talk a little bit about what we learned from the last ideas study. And what we found out was that several of the Medicare Advantage plans really didn't know a lot about new ideas. And we had to resolve those individually. And going forward, we would have to do the same. There are just so many plans out there that there's no way for us to communicate with all of them. CMS does have a mechanism, but we don't have a mechanism in order to communicate with them. And we also found out that there are MA plans out there that are not following the CMS guidelines. And the same with Medigap plans, because there's something referred to as a traditional Medigap plan, which we learned about. So unfortunately, we can't think of every single instance. And we did learn that there are some hiccups here and there, but for the most part, we're able to resolve 95 to 98% of these issues. And also just don't give up when the MA plan denies. That's what they want you to do. I think pretty much with any new procedure, their first MO is always to just deny. If they don't know what it is, they don't understand it, they'll deny it, and they hope you go away. And we don't want you to go away. We got to work these claims. We got to educate the payer and make sure they understand what the study is and that they're responsible to pay. So this is just another example with an MA plan. And it really wasn't even that they didn't know about new ideas, because this one knew about new ideas. It's just the provider didn't really give them the right information. So I won't read this to you, but it is just really imperative that you give the correct information so they understand that this patient is in a CMS approved clinical trial number X, and if you need to even give the case number. If you don't give that information, they could deny the claim because they just don't understand it's a patient that's in a new clinical trial. So it could be something just that basic, and we ran into that a little bit. So that's the end of my prepared statements. I'm going to look to see if I can get up the questions, and if not, I'll ask.
Denise, I can read them to you because I've been gathering them.
Excellent. We'll do that. Christina, thank you so much. So go ahead.
So the first question is, if the target population is focused on Latinx and African American, what is being done about the cost sharing that patients with MA, Medicare Advantage plans will be responsible for? Our African American population has much lower SES and will potentially decline enrollment if they are required to pay anything.
Okay, so that's a really good question, and it's something that we had hoped we were going to be able to include in this webinar, but at present time we don't have authorization to pay for any co-payments or to pay for any portion. So what we can tell you is ideas all along did have an intent to, when a Medicare plan wasn't covering the copay, to pay for it out of the clinical trial. Unfortunately, there's a chain of authorization that you must go through in order for the government to allow this to happen. And IDEAS has submitted everything timely. They've had communications with the agency that needs to approve this, but at the time of this presentation, we do not yet have approval to pay for them. So we do have mechanisms that will be implemented once we are able to do so, but at present we do not. So bottom line is we'd love to cover that population to ensure we get great enrollment, but at present our hands are tied. So thank you for that question.
Okay, great. So the next question is, okay, I think this was said while you were doing part of the presentation. Would the same rule apply if we global bill? You do the scan and interpret. Not sure what that means.
Yeah, so basically you're going to, the question was probably around how do I actually submit the claim? And you're not going to need to put the 26 on there or the TC. When you bill globally, you just put the Q0 modifier. So follow the examples. I think you probably just asked the question before you saw the slide, but billing globally, there is an example of how to do that.
Okay, next question is, do you know the A code for florbetaben?
So those were on the slide. Let me see if I can get back to it because I don't have those committed to memory. I'm sorry. Yeah, it's available on the slide. I can't get back to my. Yeah, so I apologize, but I can't get back to my slides now.
Okay. The next question is, can you review the part on the email that we need to keep?
Sure. So as I mentioned, what is very important is that you will get an email after you have uploaded the report of the scan. So basically, there's a process. So if you have not participated in NOPR or IDEAS, you probably don't really quite understand the entire process. But you're going to register a patient. And then after you register a patient, then the patient's going to come in, they're going to have their study. And then there's going to be the report that needs to be uploaded. And then there's going to be some questions that the physician is going to be asked. Actually, two sets of physicians are going to be asked. Once you have uploaded the pieces of information that allow you to bill, you will get an email. And so I think that's the important thing. And I see that Dr. Siegel is listening. So if he wants to add to that, because he probably has a little bit more information, but you will get an email, and it will probably go to somebody that's referred to as an administrator. And it's that email that the billers need to keep.
Yeah, I can add to that briefly, Denise. Thank you. The unlike NOPR, where the waiting period before you could submit the claim was quite a bit longer because you had to wait for the post-PET form to be completed. In IDEAS, and especially in new IDEAS, all you need is for the scan completion form to be done after you do the scan, for the PET report to be uploaded, and for the interpreting radiologist to complete the PET assessment form. When those things are done, you are finished. All the activity that's going on with the neurologist is going on independently. You won't even be able to do the scan until the patient has been consented and the pre-PET form has been completed by the neurologist. But you don't have to worry at all about the post-PET form, which is not done for 90 days until after the PET scan is completed.
Yeah, thank you, Dr. Siegel. So for those of you who don't know, Dr. Barry Siegel has been instrumental in all of these clinical trials that I've been talking about, IDEAS, NOPR, and so I was thrilled to have him be available and listen in to the webinar, so that in case any of these types of questions came up, he would be available to answer. So thank you for joining us, Dr. Siegel. So the important thing is, before Christina, you go on to the next question, is just that there is a person who's going to get this email. and you got to find out who that person is. And even though it does sound like it's a little less labor intensive with what's, there still have to be, you still have to upload things. So until those uploads occur, the email is not going to come. And that can take a day or two to happen, maybe even 3 days to happen. Once the elements have been met, once everybody does their piece, their job of uploading the form or the radiologist filling out their form, then the email will come to the designated person. And then that person should then automatically forward it to the biller. So that's the trigger to the biller. And that's the key, is hold the claim until that's all done, and then you can bill for the study. Another question, Christina?
Yeah, so the second person that asked the question about the A code, that person responded, Q code on the slide, which I believe is a hospital code, not an outpatient A code. Maybe it doesn't have an A code yet. So I actually reviewed the TOPS April Excel spreadsheets, and I don't see an A code either. I just see the Q code.
So let me speak to the Q code. So Q codes are not hospital only codes. Q codes can be used in physician office setting, IDTF setting, or basically it functions as an A code. You might be confusing it with what's referred to as a C code, which is a transitional pass-through code. And that is a temporary code that can only be used by hospital outpatient setting. So the Q code, the Q9983 code, because I did print that up, that's phlebitabine, and that's the life molecular code. That is acceptable in both settings, if that's the question.
Great, thanks, Denise.
Yeah.
The next question is, any idea of cases ideas 2 will have versus ideas 1?
Dr. Siegel?
Repeat the question again.
Any idea of the number of cases ideas 2 will have versus ideas 1?
Yes, okay, good. Fewer. We're only approved by Medicare to accrue 7,000 total patients. And of that 7,000, we're targeting that at least 4,000 of them will be from the African American and Latinx communities.
Thank you.
Thank you. Next question is, does the 1 scan per lifetime apply to patients enrolled in ideas 1, or can they still be enrolled in ideas 2?
Should I take that one again, Denise?
Sure, go ahead, yeah.
One of the eligibility requirements is that a patient's amyloid status is unknown.
Right.
Therefore, if they had an amyloid scan in ideas 1, their amyloid status is known, they're not eligible.
Besides the fact that Medicare is only paying for 1.
Well,
anyway.
that's assuming Medicare knew how to track it, which is probably
Exactly.
not correct, but be that as it may, it's the patient's not eligible.
Correct.
Okay, next question is, would you mind speaking to the process for pre-authorization for Medicare Advantage plan recipients, or is this too specific to the plan? I think that person responded that she got most of it late, because I think you spoke to it later, but if you want to just briefly talk about it.
Yeah, I mean, just in quick summary, that you follow the same rules you would no matter what type of study you're getting prior authorized for the MA plan. So if you are familiar working with a particular local MA plan, you follow their process. But as I showed you on that slide, you have to make sure you give them all of the information, including telling them that this is part of the new ideas clinical trial, and give them that clinical trial number.
Okay. The next question is, so the isotope is not reimbursed separately in a HOPPS system. If it's a bundle payment, won't we lose money due to the high cost of the radio tracer?
So I'll let you take that, Dr. Siegel.
Oh, bless your heart. The answer is yes. But that's a big generic problem, and it has way more to do than just new ideas. But the principle that Medicare uses is the average cost of the radiopharmaceuticals, and of course, that average cost for PET is dominated by the 95% of the PET studies that are done with FDG. The Society of Nuclear Medicine and others are working on trying to solve the problem with Congress, but it's not a done deal yet. Some hospitals have agreed, mine is an example, to participate in new ideas, recognizing that there will be a loss because of the programmatic importance of participating in Alzheimer's disease research.
Yeah, Dr. Siegel, yeah, that was actually a very good way of saying it. That in the hospital outpatient setting, the way Medicare looks at it is that you're paid on an average. So you'll be overpaid for some studies and you'll be underpaid for other studies. But in the end, it should average out, and they expect that hospitals would take care of all of the Medicare patients equally. So that is, and they expect that you should put the true costs on your claim forms, because that claim information is captured and can contribute to future payments 2 years out. So thanks for that question.
Okay, the next question is, are patient data also uploaded on hospital/clinic PACS system with the reading, and should they be part of patient records, although it's clinical trial study? Yes, it's a clinical trial study.
Yeah, I mean, go ahead.
Yeah, go either way, Denise. This is the research in new ideas is actually a study of physician behavior, how the neurologists change their management, and it's also a study of the relationship of the PET results to patient outcomes. It has really nothing to do with the scan itself. The scan is considered a Medicare-covered clinical procedure under the conditions that the patient is participating in the new ideas study. Therefore, the information, the report, and the images need to be part of the medical record.
Agree. Christina, why don't we take one or two more and then we'll close it out.
Okay. In the non-hospital setting, is there a 20% coinsurance applied to the radiopharmaceutical cost as well as the procedure?
Yes, that was on one of the slides.
Yep.
And then as I mentioned, generally, patients will have a Medigap plan that covers for the copays or deductibles. And so we anticipate that just like in past studies that most of those are picked up. And in the cases where they don't have a Medigap plan, then the patient is responsible.
Okay, great. How about Medicaid, Medicare coverage? I'm looking back at my first ideas group of patients, and it looks like I had one Meridian patient, which is a Medicaid plan.
You had one, what'd you say, Noridian patient? Noridian is not.
They said Meridian. Meridian.
Yeah, I'm not familiar with Meridian, but they also said Medicaid, and
Yes.
so to my understanding, no Medicaid patients were entered into the study.
Correct. Yeah, well, yes and no. So the truth is, a patient who only has Medicaid is not eligible. Medicare has to be the patient's primary insurance. However, a dual eligible Medicare patient, a patient who has sufficiently low incomes to also be eligible for Medicaid. Medicaid, as the secondary insurer, may function as the equivalent of the patient's Medigap policy and may cover part of the copay expenses that Medicare does not. I think we had very few such patients in ideas and don't know how many we'll have in new ideas.
Right, but I think the key is that it was only covering part of it. It was not covering the primary piece.
Correct. Medicare has to be the primary coverage.
Right.
Okay, we have 3 more. If we could just finish them out.
Okay, Christina, go ahead.
Sorry. Last ideas, we had difficulty with referring doctors telling the patients there was no copayment and no deductible. Are referring doctors receiving the same information as the providers?
I don't have information on that. Do you, Barry?
Well, we are making that information clear as part of our training of referring physicians. It's also very clearly laid out in the consent form. And the consent forms this time around are going to be absolutely uniform because this time we are using a single IRB and we are not allowing any variation in the consent forms other than institutional boilerplate related to things like liability and stuff like that.
Okay, great. Is there a timely filing guide for submitting claims and uploading the reports?
Well, yeah.
Go ahead, Denise. My recollection is that the report, the PET completion form needs to be done the day the PET is completed. The upload of the PET report and the interpreting physician PET assessment form, I believe, still need to be done within 7 days.
7 days. Yeah, I had a slide that said the 7 days, but when you say timely filing, to me, that also means Medicare. And there are rules that Medicare have as to when you have to file, which is basically within a year. And then if you file and then you're appealing, then there are timelines on the appeal process. So hopefully that answers all the different iterations.
Presumably no one will want to wait a year to file their claim.
Yeah, we hope not.
Okay, and last but not least, will PAMA CDS, clinical decision support, be applicable to the IDEAS study?
Great question. My guess is PAMA will be totally blind to this. There probably are not even PAMA criteria for amyloid imaging. And fortunately, probably during the timeline when this is running, referring physicians will be able to override what PAMA is telling them because only tracking will still be being done at this point. So I don't think it's going to be a problem.
Yeah, I agree. I think it's a non-issue at this point. If it becomes an issue, we certainly can give guidance on it. But as it stands now, everything is still voluntary, and we're not even sure when it's going to become mandatory.
And even when it does, it's not supposed to absolutely block the study for at least the first couple of years.
Yeah, and it won't block. Yeah, it would never block the study. It would only require the physician to do prior authorization. So you're still going to get paid for it. They just want information for several years. So I think by the time that all occurs, new ideas will be old ideas too.
Don't hold your breath.
Great. Well, thank you both so much for the presentation, and thank you to all the attendees for joining. Questions as to whether this meeting is being recorded, it is, and so that recording will be available on the SNMMI website and on the New Ideas website. Have a good afternoon.
Thank you, Christina. Thank you, Dr. Siegel.
Thank you. All right. Bye.
Bye.